Larry Geier. I'm a medical oncologist from Kansas City. I've been a medical oncologist for a long time, 30 plus years. And do I have any medical oncologists in the group? None, okay. Oh, one, okay. So we spend most of our time, I spent most of my time over my career chasing cancers. We're always on the back end of things. And much of my career I would be sitting with somebody with a new diagnosis of breast or colon or whatever cancer, particularly if they were young, and looking at that family history and going, could we not have seen this coming? Could we not have intervened somehow, kept this from happening so that we didn't have to deal with this tragedy? So I always had this kind of preventive bent about me that went largely untapped because for the most part we had no tools with really to work with to identify who the people were who were destined to get these cancers. And then along came the genetic age, and we started unraveling some of the mysteries about these families that we knew had to exist. We knew there were bad genes decades ago. We just didn't know what they were and how to go about anything. But like many oncologists, in the first 10 years of BRCA testing being available, who were the patients that we found? Only the ones that had the slam dunk family histories, right? That's what we were on the lookout for. Oh, you've got breast cancer, your sister had breast cancer, mom, Aunt Sally, grandma, grandma's sister. Those are the ones we found. And we missed everybody else. So we've had BRCA testing available now for 18 years, and we haven't even found 10% of those Americans that are walking around with a bad BRCA gene. So my talk today is kind of, I try to make it very clinical, very pragmatic. I use lots of cases, try to fill in the blanks. I think a lot of people in this room, if you're here to begin with, you already know something about all this. Try to fill in some blanks and show where we're still missing the boat. I'm going to be talking about BRCA primarily. I will touch some on Lynch syndrome, which is always something a little extra special when I get to have one of the doctors Lynch right in front of me in the audience, so no trepidation there for me. But anyway, these are the relatively common hereditary cancer syndromes. We've just heard about the HBOC with the BRCA genes and Lynch syndrome with the mismatch repair genes. I want to give just a glancing blow to the colon polyposis syndromes, the ones that sort of led the charge because they had a phenotype that was so compelling that they didn't get missed. What you may not know is the more common phenotype is missed all the time, the non-classic FAP. But we're not going to go in much into that. These are the hallmarks of hereditary cancers. These are the things that we should be on the lookout for when we see our patients. Number one, family clustering of specific types of cancer in the generation or across multiple generations. Well, duh. I mean, this is hereditary. Shouldn't there be family pattern? Well, one of the points I want to make is you'd be surprised how many times in one of these families the family pattern is not that compelling. It's just very subtle, and there's lots of reasons why that can be. Younger age at diagnosis. You're born with a bad gene. You're programmed to get cancer from day one. Stands to reason that you have a head start on other people and you might get there sooner. So that's the basis for being aware of the young breast cancer or the young colon cancer as a key clue. Multiple cancers in the same person. If you're programmed to get cancer once, you're programmed to get it again. If you got breast cancer and you had a lumpectomy and you still have 1.8 breasts remaining, guess what? If you have programmed to get colon cancer and you have a partial colectomy, guess what? So multiple cancers, not necessarily just in the same organ, but in companion organs, that is breast and ovarian cancer or colon and uterine cancer in the same person. So multiplicity is a key clue. And then typical phenotypes in some cancer, and by that I mean characteristics of the cancer itself. In Lynch colon cancer, it can be the location of the cancer or the histology can provide clues. In breast cancer, it might be the triple negative, and we'll talk about that a little bit more. And the unifying thing here in all of these syndromes is that the genes in question fall into a category of what we call tumor suppressor genes. Simply put, these are protector genes. Genes that are supposed to be in the on position, and one way or another, they participate in maintaining the integrity of all of the rest of the genes. Okay? So you saw the Fanconi pathway, and we could show the mismatch repair pathway, but these are all good guys. And the problem comes when you inherit a defect in one of those good genes, so it doesn't work. So that's the unifying thing. So I take that big slide, and this is what I use in the back of my head when I'm seeing patients. I call it my FAMP approach. The only reason I use FAMP is because I couldn't take those 4 letters and make any other word that made sense. But family, age, multiplicity, and phenotype. And for me, that's just a little checklist going on as I'm analyzing a pedigree or a patient's individual cancer. So why should we care about all of this? Well, we've already talked about the prevention strategy. You know, cancers that were destined to occur that we can now prevent. I think that's fairly easy to get a handle on. You know, there are quite a number of cancers that are at least conceivably preventable, or if under appropriate surveillance, caught earlier at a much more curable stage. So I've listed here a handful of cancers, and this is actually a little bit of an old slide, but this pointer is just not going to get it done. So when I say 5 to 10% of breast cancers are hereditary, or 13 to 18% of ovarian cancers, those numbers are being revised upward now. And so we think that there's a more significant proportion. But many of those cancers are either totally or nearly totally preventable if we only knew who to prevent them in. And many of them have effective surveillance, but not all. But this is the other part of the story. This is the part that's kind of evolving now, and that has to do with management implications. I don't know how many of you have ever had this scenario happen, but it was regular fare for us in oncology. A woman is diagnosed with breast cancer. She may be young. She may have a family history. We're thinking about BRCA testing, but this patient is going to need surgery and chemotherapy and radiation treatment and God knows what. Ma'am, you got a lot on your plate right now. We're thinking about those genes, but we're going to get to that later. All right? We're going to put that on the back burner when the dust has settled. All right? I've had that conversation myself dozens of times, and my partners have as well. Well, that was all fine when it was all about prevention of the future cancer. All right? Job 1, beat the cancer you got. Job 2, prevent the future. But wait a minute. We're just finding out that some of these cancers are biologically distinct, and that this may have an impact not only on prognosis, surgical decision-making, but sensitivity to chemotherapy. So there's already been some talk about prognosis, but here's sort of what we know right now, and that is Lynch colorectal cancer, stage for stage, has a better prognosis than sporadic colon cancer. Same is true for BRCA ovarian cancer. Here's a new finding. The triple-negative breast cancer that's related to BRCA may have a better prognosis than sporadic triple-negative breast cancer. We'll come back to that. And Dr. Janicek mentioned that BRCA prostate cancer, conversely, is a bad deal. All right? And so in this age when we're starting to do less and less for prostate cancers, we've been over-treating them perhaps for the last 10 or 15 years. Whoa, not if you got a BRCA bad gene or a bad BRCA gene, that needs to be treated aggressively. Surgical decision-making. Well, the most obvious case here would be a newly diagnosed breast cancer patient, candidate for lumpectomy. Is that in her best interest? Should she consider bilateral mastectomy? Well, how would you know if you didn't do the testing right out of the gate, all right, so they can participate in the decision-making? Or in the Lynch situation, where we've got colon cancer diagnosed in a patient with Lynch syndrome, should they have a segmental colectomy, a hemicolectomy, a total colectomy? It's at least a subject for discussion. And how about that same person, if she's female, She's got Lynch syndrome, she's heading for definitive colon cancer surgery, and she still has her uterus and ovaries in place. Might we want to know that before we go to that surgery? Well, that's a little bit harder to get into the mix, but I will show you some cases where we have been able to do that. Chemosensitivity. Lots of play in the last few years about the role of 5-FU in colorectal cancer in either Lynch syndrome or in any colon cancer that demonstrates microsatellite instability. Here's something that's coming down the pike. All right, if you're an oncologist and you do neoadjuvant chemotherapy on a breast cancer patient, we typically expect maybe a 25% complete response rate pathologically with that chemotherapy. But in the BRCA positives, using platinum, which is not a drug we would normally use in breast cancer, there's been multiple studies, a growing database, let's say, that the pathologic CR rate approaches 70%. Well, how would I know to use platinum in my neoadjuvant chemotherapy if I didn't know they had a bad BRCA gene? PARP inhibitors in BRCA ovarian cancer, a new class of drugs that are just like tailor-made for BRCA positive patients. Lots of stuff presented this year at ASCO about how much more beneficial these are in BRCA ovarian cancer than they are in sporadic ovarian cancer. Again, how would you know to use it? So the point of all of this is this needs to be front-loaded as much as possible. This is part of what we have to consider right out of the gate, soon after diagnosis, if we're going to optimally manage these patients. So here's a typical age versus cancer risk curve. This is, the blue line is the normal woman for breast cancer. The red line is my mom or my sister had breast cancer, an approximate doubling. And the green line is I've got a bad BRCA gene. And you can see how much younger it leaves the baseline and how much more steeply it climbs, so that the lifetime risk is in the ballpark of about 80%. You can have a similar curve for ovarian cancer, the only difference being that the lifetime risk in the normal woman is a little over 1%, BRCA2 somewhere in the range of 20 to 25%, and BRCA1 upwards of 40 to 45 to 50%. So there is a difference there. I want to make a comment about the triple negative, and if you're not used to dealing with breast cancer patients, let me define that term. We do certain tests on every breast cancer patient: estrogen receptor, progesterone receptor, something called HER2. If you happen to be negative for all three of those, that tells us that you have a particular flavor of breast cancer that historically we have thought was a bad actor, and we treat those patients quite aggressively. Several years ago, it was determined that, gee, a lot of these triple-negative breast cancer patients had underlying BRCA mutations. Several studies have now been done showing that that is in the range of 15 to 20%. Our own study in Kansas City, which we reported at ASCO this year, we had 165 unselected triple-negative patients. That is consecutive. Don't tell me anything more about them. And we did BRCA testing on all of them, and it was about 16.5% that were BRCA positive. So that makes triple negativity a key clue. Now it's been included in the NCCN guidelines. The only difference is they put an age with it, triple negative less than 60, because the first two studies that came out had nobody that was over 60. In our study, we have 2 people that are over 60. So I predict that over the next year or two, you're going to see that age part disappear, and it'll be all triple negative patients. Well, part of the problem is we've been dealing with triple negative patients for 10 years, 12 years, whatever, that we've identified that as a subgroup. This has only been a guideline for 2 years, all right? So what about all those other triple negatives that came along before that? And how do we make sure that we're capturing those people? So these are the kind of the red flags. These are, in my mind, these are the things that should get you to think about it, to do a more focused genetic evaluation, not necessarily for testing purposes. So breast cancer before 50 or premenopausal, there's our age part. Triple negative, there's our phenotype part. Any epithelial ovarian cancer, any woman with multiple primary cancers, that is multiple breast cancers or breast and ovary, any male with breast cancer, either of those cancers in a Jewish woman, and then comes our F part, the family, 3 or more relatives with either breast or ovarian cancer within 3 degrees. So that's kind of the, all-encompassing to get the FAMP and collect these people. So as I said, with 18 years, still not doing very well. So now we have a bunch of automatics. These are designed so that doctors don't have to think. These are things widely accepted, Medicare, Medicaid, almost all payers, that you have one of these features, you're appropriate for testing. So breast cancer by age 45, and that does include DCIS. Any epithelial ovarian cancer, regardless of age, any male breast cancer, again, the triple negative by 60, either one in a Jewish woman, or 3 cancers within 3 degrees for most payers, the notable exception being Aetna. So those are automatics. And I would say that, hereditary breast cancer is more common than you think. For years, we've been saying 5 to 10%. And I think in this new era of expanded testing, finding more genes we wouldn't have otherwise looked for, we're going to see that number go up. A lot of people think it's going to be closer to 20%. And it's much higher in the Jewish population. And once again, DCIS is just as important. So Dr. Janicek showed an impressive list of other genes that can be tested for. These are the key ones that have significant breast cancer risk. And I would tell you that not all of these are low penetrant genes. There's new data about Cowden syndrome, for instance, where we used to say 20 to 25% lifetime breast cancer risk, that think that that's much higher than that, and that it's more common than we ever thought. The same could be true for Li-Fraumeni. Some of these other ones do have lower penetrance, and we're uncertain in some of these cases, what do we really do with the information? But as was mentioned, what's coming is the ability to test not just for BRCA, but for other genes as well, either sequentially or simultaneously. So I know that when we started looking at this several years ago, and I will point the finger at myself just as well, if you'd have asked me 8 years ago, so doctor, you got a handle on this BRCA stuff? You on top of this? Kind of important. We all would have said, oh yeah, we're totally. I just sent one off last year for testing. I'm on top of it. And if the second question was, so, I'm curious, how many BRCA patients do you actually have? Well, I don't actually have one. I think about it all the time, but I don't actually have a patient. It's very rare. I'm unlikely to see one in my career, maybe 1, maybe 2. That was our default position. And sadly, as I go around the country talking to a variety of doctors in situations like this, it's still the default for a lot of people. So, how prevalent is it? We don't really know the number, but best population estimates put it somewhere in the ballpark of 1 in 400 Americans walking around with a bad BRCA gene. I'm not saying they're diagnosed, I'm saying they're walking around with it. Unless I'm talking about a Jewish population, where it's 10 times more common, 1 in 40, all right? So I don't know if you have a large Jewish population that you deal with in practice, but you have to be just extra vigilant about that. We've had BRCA testing for about 18 years, and again, maybe 8% approaching that in terms of the number of people who have actually been diagnosed. So what do we do with a patient that we have found a bad BRCA gene in? Well, it depends a little bit on whether they have had cancer or not had cancer as to what we're kind of do. But no matter what your situation is, it's a complicated set of things to consider in terms of what are we going to do. So every person is individualized in terms of that menu of options. And a big part of this is, what is her perception of her risk for future cancer? I can throw out numbers. I can say 80%. But if you're a woman who lost her mother to breast cancer when she was 42, and you lived that up close and personal when you were a teenager, and her aunt had breast cancer with a bad outcome, and grandma died from breast cancer, you have a certain view of what breast cancer is all about, right? You could be the same woman whose mother, aunt, and grandma all had breast cancer, but they're all alive and well. They were survivors. It was a bump in their road, right? You have a different perspective on what you're willing to do to avoid that risk. So all of these things have to be taken into account, and I'm always amazed at what the choices that women will actually make. But this is the menu of risk management strategies for BRCA carriers, kind of increasing effectiveness for prevention. And we'll sort of talk about these one at a time. So high-risk surveillance, basically the key phrase is breast MRI, all right? Starting at age 25, all right? The only reason we would start earlier than that is if there was an extraordinarily young breast cancer in that family. So in other words, if her mother had breast cancer at 29, I'm not waiting till 25 to start screening this woman. We hold mammograms back until age 30, and then we alternate that with MRI at 6-month intervals. Now, Dr. Janacek said, and I would certainly echo, that sonograms and CA-125 levels are not effective screening for ovarian cancer, but we start them anyway at age 30, at least I do. What am I going to do? The patient doesn't want to lose their ovaries yet. These are the only tools I have. I'm hoping to stumble on something. But they all know that this is not effective and that we cannot breathe too easy with this approach. Melanoma and prostate screening may change as well in people who carry a mutation. I'm not going to talk about lifestyle. There's not really much to say there. Chemo prevention, the use of medications to lower risk. So for breast cancer, it's all about tamoxifen. We don't have any prospective randomized trials. All the trials are in some way or another retrospective, but there's pretty good evidence, and another study was just published about the effectiveness of tamoxifen in both BRCA1 and BRCA2 carriers, lowering breast cancer risk by about 50%. You get the same benefit if you lost your ovaries by the early 40s. I haven't seen the data that Dr. Janacek briefly alluded to, that maybe there's benefit even postmenopausal removal of the ovaries in terms of breast cancer risk, but that's not going to be in the ballpark of a 50% reduction. So I will quote that reduction level if a person has their ovaries out by the early 40s. The other drugs that we use for breast cancer prevention, Evista, Arimidex, those things, none of them have been tested in the BRCA population. Oral contraceptives. I've had women sent to me after they were diagnosed with a BRCA gene by somebody else saying, well, now I have to get off birth control pills because that could increase my breast cancer risk. And the answer is no, it does not. That is, routine premenopausal use of OCP does not exacerbate the already high breast cancer risk. All right? Conversely, there's clearly a benefit in lowering the risk for ovarian cancer. And the magnitude of that benefit is proportional to the number of years that the patient took OCP. Now, I don't know this literature backwards and forwards. There's a number of studies out there. But my goal when I see these patients is, as long as you have your ovaries, if you're not trying to actually get pregnant right now, I want you on OCP so that I can minimize the chance of the cancer until we get to the part where you separate yourself from those ovaries and tubes. So that's my approach there. Risk-reducing surgery. Heard plenty about Angelina Jolie and what she chose. There are various types of preventive mastectomy that reduce the risk of cancer in the breast. When you look at the data and you quote, well, how effective is this? You have to be aware of what the time frame is that that study was done. So for years, the number that was quoted, how much can you lower your breast cancer risk by having a double mastectomy? The number thrown out there was 90%. And that was from a New England Journal study from way back when. The problem was that study included lots of people who had subcutaneous mastectomies. That is, they were not willing to have a total mastectomy. They wanted to retain sensation and the nipple, etc. So on purpose, breast tissue was left behind. Those were the people that got subsequent breast cancer. In the more modern era where we're doing total mastectomies or even modern nipple-sparing mastectomies, the largest study reported to date had 0 people subsequently get breast cancer that had complete mastectomies. So let's just say it's highly effective, and doctors never say 100% on anything, so I usually quote very close to 100%. Preventive surgery for the ovaries and tubes obviously can reduce that risk extremely well, as also does leave that residual risk for primary peritoneal cancer that's already been talked about. And as we've already said, you can get a reduction in your breast cancer risk when your ovaries come out soon enough. This has already been talked about. I just want to, our target for getting rid of the ovaries and tubes is 35 to 40, just like he said, or whenever childbearing is complete. So if a woman says at 32, I'm done with kids, I'd like to have my ovaries removed, we'll do it at 32. And this is a cancer operation because there are, in various studies, somewhere in the ballpark of 4 to 10% of people that will have occult malignancy that was not suspected preoperatively. That's people who are having preventive surgery because of bad BRCA genes. All right? So we don't want to get the call 2 days later from the pathologist, sorry, but I found a cancer in that fallopian tube. I hope you did a cancer surgery. No. So this is why it requires both meticulous operation and a certain protocol to be followed, as well as dissection by the pathologist. The question that comes up sometimes is, all right, now I've got that 35-year-old that I just took her ovaries out and threw her into menopause. Can I put her on estrogen, or is that going to make her future breast cancer risk even higher? All right? The answer is, if the uterus is gone as well, so that you can put them on estrogen only, there is no exacerbation of their breast cancer risk. There are all those good reasons to be on estrogen between 35 and 50, in terms of long-term health. So when that study has been looked at, those people did not have increased breast cancer risk. In fact, they had fewer breast cancers develop than people that were given nothing. But you can't give estrogen alone if the uterus is still there. And we don't have data that giving estrogen and progesterone is safe. So there is a conundrum that brings us back to whither goeth the uterus at the time the surgery is done. An area of plenty of controversy out there, and I'll leave that to others. All right, let's do a case I promised. This is a 51-year-old woman with invasive ductal cancer, happens to be triple negative. This is her second go-around. She had breast cancer at 42, also ER negative, because that was before we knew about HER2. Mother had breast cancer at 44, sister had ovarian cancer at 49. There are the red flags, just in that little description, and there's the pedigree. All right, so here's our patient here. There's her mother. There's her sister. So having said, or knowing what you know and what we've already said about the red flags, who among you would miss this family? Please don't anybody raise their hand. All right, so the real question is, who did miss this family? And the answer is, only every single doctor and nurse taking care of this patient. All right? It makes me sad every time I see it. And the patient died of metastatic breast cancer a couple of years later. And then the question was, well, what about her 2 daughters, age 30 and 32? How are we going to manage them? Looks like they're in the crosshairs. Breast cancer's coming their way, right? So both were advised in their early 30s to have annual mammograms, and the older daughter had a very progressive gynecologist who said, ooh, MRI, pelvic sonogram, CA-125, we're going to do the works on you. What I call painting the whole family with the same brush. So 2 years later, the younger of the 2 daughters is diagnosed with breast cancer, shortly after having had a normal mammogram, by the way. And she also has a triple negative breast cancer that's already in 3 lymph nodes. And this is her here. All right? So now we've got 3 generations, and we're a little bit smarter, and so she actually goes through DNA testing and has a mutation in BRCA1, And in my slides, if you're positive, you're red. So, without talking any more about that patient herself, what about the sister? How would you like to be her sister? All right? In the traditional view, what would you think is your risk for getting breast cancer? Doomed. All right? How about ovarian cancer? Well, maybe yes, maybe no. All right? So anyway, she was doing all this high-risk surveillance, but with her sister, we found what the mutation is. We found the key that unlocks the puzzle for the rest of the family. She gets tested. She is a non-carrier. All right? So, what's her risk for breast cancer? Average risk. Risk for ovarian cancer? Average risk. So she's been getting too much stuff done. So it cuts both ways. Well, there's when we're done with the whole family. So it turns out the brother is a carrier, and he has 2 daughters, one of whom is a carrier. So now we have a very young woman identified. She is standing on the railroad tracks, and the train's a-coming. All right, we just don't know when or what train. But we're going to be running alongside of her whole life to try to keep her from getting hit by that train. This patient's children were too young to be tested. Let's look at this case from another vantage point, which is a timeline. Here's mom's first breast cancer, 1997. Her sister's ovarian cancer. Her mom's second breast cancer, 2006. The daughter's breast cancer, 2009. And the question is, at what point should this family have been figured out? If you were using today's red flags, today's automatics, when would you figure this family out? Here? This is when everybody missed it. Here? Here? All right, nods. All right. So the answer is here. She was 42. That's less than 45 where I come from. And so if this was today, she would have been automatically tested. We don't know what other people would have done, but we could have potentially prevented 3 cancers and 2 deaths. And maybe there will be a 3rd death. We don't know what's going to happen with a young woman. So that is the point of this on the prevention side. So to me, that's a straightforward case. I can't imagine that being missed, but they still are. Here's another case. Here's a 60-year-old woman. She's in for routine follow-up of her previous breast cancer. She was ER positive. She had a mastectomy, had tamoxifen for 5 years. The only other breast cancer in the family, a paternal aunt at 63. Her father had melanoma, grandma had pancreas cancer. All right? Slam dunk, right? No. I mean, that's not very suspicious. Let's look for the red flags. Oh, there are none. So, who among you would capture this patient? All right? What's missing in this little story? I hear blah, 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 blah. Spit it out. Initial age of diagnosis. All right? This doesn't tell you that. But this does. She was 40 when she had her first breast cancer. She's coming in for routine annual follow-up of her previous breast cancer. Now, this is my patient. All right? This was actually one of the very first patients I ever had when I got to Kansas City. I can't get rid of her. She comes in once a year. She lives 100 miles away. She wants to come in once a year and be blessed by the oncologist that all is well and go shopping. Not necessarily in that order. So she comes in, and for years I'm seeing her, and this is prior to my age of genetic enlightenment. All right, so I'm just as bad as all the other oncologists. I'm just happy to see her doing well. All right, so once I get into this genetic arena, and she comes in, and I say, "So Judy, how old were you when you had your breast cancer?" Yeah, I'll never forget. I got the call on my 40th birthday. Really? But you didn't have any family history of breast cancer, right? She goes, "No." Well, my dad's sister had breast cancer, but that's on my dad's side. And everybody knows breast cancer comes down on the mom's side. Really? Well, long story short, this is the message. It's all women who were diagnosed at 45 or younger, I don't care how long ago it was and what age they are now, are appropriate for testing. And she did, in fact, have a BRCA2 mutation. And there she sat with her other breast and both ovaries and tubes. All right? So she didn't undergo a risk-reducing surgery for those two things, no findings. But when we were done, we had her daughter, curiously also at age 40 now, was a BRCA carrier. Dad had melanoma, mom had cancer of the pancreas. So remember before when I talked about BRCA2, there is a broader array of cancers in BRCA2. Melanoma and pancreas are both in that. This woman here was dead and couldn't be tested, and she had no children. So that's why that goes. And the two siblings were negative. So all of this is pointing to the survivor population. All right? It's fairly easy in the era of automatic testing, all right, to capture most of the newly diagnosed patients. We either get them by age or family or phenotype or something, multiplicity, all right? But what about the people that are rolling through over and over again who had their cancer 8 years ago or 12 years ago or 4 years ago when the guidelines were different and you didn't capture them then? Well, you have to pay attention to these people, all right? To their age at diagnosis, their phenotype, triple negative particularly. You need to review and update the family cancer history. Oh, there's a good one, all right? We all take, I don't care what kind of doctor you are, you take a family history when the patient first comes to you, right? There's some kind of form they fill out. It's all in there in the database. You do your dictation, you outline the family history. How many are taking an updated family history every time? You don't count. Every time the patient rolls back in, or at least on a regular basis. All right, there are some, all right, because hopefully we're paying more attention to this stuff. But I can tell you how it was in oncology. When you first see the patient, any other breast cancers in the family? No? All right. If I'm really on top of my game, how about any ovarian cancers? All right. No? On to review of systems. We're done with the family history. And it's never going to be come back to again unless the patient walks in and says, guess what? My sister just was diagnosed with breast cancer. Well, let's talk about what patients are going to tell you. If they think it's a relevant cancer, they probably will tell you when they come back in. But what if it's not a relevant cancer? What if we're talking about colon cancer patient and she knows that you're interested in other colon cancers, but what really happened was she just found out that her aunt had endometrial cancer. She doesn't think that's relevant. She's not going to offer that up if you don't ask. So there is an art to taking a family history. It's pretty darn simple. You got to just ask a couple of questions. But that's the point of all of this. So anyway, I will show data later about what we found in our own survivor population. BART's already been alluded to a little bit. It's the test that sort of sat out there for several years, and some insurers would hide behind, oh, it's experimental and new, until NCCN in 2011 finally came along and said, no, if you qualify for BRCA, you qualify for BART. Most insurers then fell in line behind that. Well, again, I might have tested somebody for BRCA back in 2008. BART was, denied. If they qualify for BRCA then, they qualify for BRCA now, and they need to have BART. Yes, ma'am?
Is that true for the Ashkenazi Jewish population as well?
Is what true?
What you just said.
Okay, it depends. So for the Jewish population, if the main reason that you're being tested is because you're Jewish with breast cancer and you don't have a big old family history, then no, it's not true. All right? But if at the time that we did your testing for the Jewish mutations, the 3 genes, and that was negative, and you reflexed to full BRCA because there was enough family history or enough age issues or something that you qualified for BRCA, then the answer is yes. All right? So I have to know kind of what was done. So just being Jewish with breast cancer doesn't get you to BART, but if you qualified for BRCA, you qualify for BART.
What Joyce was going to mention here, the Hispanic populations of higher incidence of rearrangement. So if we're speaking about ethnicity, I think I agree with everything you said with the Ashkenazi, but here in the Southwest, pay attention to your Hispanics, because they historically had a higher incidence of rearrangements, so those you definitely need to especially.
So that is a unique population that we're just starting to understand more, but if there's anybody you're going to be paying attention to, it is the Hispanics.
So how the Jewish population do you specifically Nazi Jews, or all Jewish people with high risk groups?
Everybody hear that question? Does it only apply to Ashkenazi Jew or anybody who's Jewish? In my opinion, I don't care whether you're Ashkenazi or not. Matter of fact, I don't care if you're a practicing Jew or not. What I care about is, did you come from a place where the Jewish population was common? There's some very interesting history about migration of peoples and stuff over the centuries, but clearly the Jews that went to Eastern Europe, the so-called Ashkenazis, they have these 3 mutations that show up over and over and over again. But prior to the migration of the Jews from the Middle East, some of these mutations had already occurred, all right, as well as others. And they went to Spain and became Sephardic Jews, all right, so-called. Well, and then some of them converted to Catholicism during the Spanish Inquisition. And so for the subsequent several hundred years, they think they're Catholic, all right? Well, some of those people ended up in the United States. There's a fascinating story of an area in Colorado, I forget the name of the river valley, where the population is a combination of Hispanic and Native American, loaded with breast and ovarian cancer until somebody figured it out, and they all have one of the Ashkenazi Jewish mutations. All right? And they go, we haven't had a Jew in our valley for the last 300 years. Well, guess what? All right, so when they trace it back, it traces all the way back. So very interesting stuff. So to answer your question, I don't pay attention to the Ashkenazis since that's where the database is. All right, how about another case? Here's a woman who's 50 years old, but she had breast cancer at 42. So this is another woman identified in our survivor identification program. 8 years after her cancer, she turns out to have a BRCA2 mutation. Grandma had breast and ovarian cancer. Dad had prostate and had breast cancer. And this is that family tree. All right, she has, again, preventive surgery. Nothing is found. And then it comes time to look at her siblings, and her brother and her sister refused to be tested. Why would they refuse to be tested? The most common reason is the fear of genetic discrimination. All right? Oh, I'll lose my insurance, they'll raise my rates, blah, blah, blah. So they could not be convinced. Matter of fact, they didn't even present. They just said, not going to do it. So, all right, so we went on to the cousin on that side of the family. She said, I'm not scared. She gets tested and she's BRCA positive. All right, she's not had cancer. She's presented with her various options, and she goes, I'll go ahead and have my ovaries and tubes removed, but I'm not thinking that I want to give up on my breasts. Put me under high-risk surveillance. Okay, great. So she has a preoperative evaluation just to make sure that there's no surprises when they get in there. Everything looks perfectly normal. She has her surgery, and she's found to have an occult stage 1 cancer in the fallopian tube. All right, this is exactly that circumstance I was talking about before of that 4 to 10%, whatever the real number is, of unexpected cancers found at that time. So, a lucky lady there, and she then said, well, sign me up for that double mastectomy too. As long as I'm avoiding trains, let me avoid that one. And the original siblings of the patient, the siblings of the original patient that had refused, now got religion and decided to go ahead and be tested. And this is what we found again: the brother positive, the sister negative, a daughter positive. The original patient only had one child, a son that was negative. So again, several different messages there. Yes, sir.
Thank you. Regarding the siblings that initially declined testing, Could you educate us a little bit about the Genetic Information Non-Discrimination Act?
Okay. So the GINA law is a federal law that went into play in 2008, so 5 years now. Prior to that, there were state laws in most states protecting against so-called genetic discrimination. And they were variably toothy and effective. But when the federal law went in, and by the way, the federal law went through both houses of Congress without opposition, possibly the last time that will ever happen in the United States. But that law says that having a genetic trait is not the same as having the disease, the cancer. And we're not just talking about cancer traits, this is more broad. Having a genetic trait can never, ever be considered a pre-existing condition for insurance purposes. So that's the key buzz phrase. Insurance companies not even allowed to ask, all right? They're not allowed to have, to ask you that question or to get access to that if you don't want them to, all right? So medical insurability is protected. Employability is similarly protected. And a question that comes up sometimes, what about life insurance? That is not protected. It's not an issue. I have yet to have a single person try to get life insurance who couldn't get it because they had a bad gene. I've never seen anybody come back and say they were even asked the question, but it's still not protected under the law. All right? So I can tell as much as I can tell anybody that, you know, you're protected from concern. So long gone are the days of clandestine genetic testing where we used to keep the stuff down in a secret drawer. All right, and it wouldn't be in the main medical record. Well, how are doctors supposed to communicate and effectively manage these risks if it's all happening, you know, secretly? So it's a much better situation that we're in now, and to my knowledge, there hasn't been a single case brought forward. Yes, sir.
Looking at all these family trees with all these risk factors, are there certain guidelines starting to develop on the age in which some of these gene testing should be recommended for some of these patients?
Are you talking about in the next generation? Yeah. Well, the stock answer for that in traditional genetic parlance is when they're adults. For the most part, on most of these syndromes, we're not talking about cancers that affect children or even affect adolescents. So genetic tradition is that you wait until they're of legal age and can make their own decision about whether they want to be tested. Now, having said that, every once in a while that just isn't true. One of my very first patients with Lynch syndrome had her first colon cancer at 17. She had her second colon cancer at 22. All right? So, you know, if we could go back in time and be looking at that family, you'd want to know sooner. Now, that's a fluke, but still. So it is for most of these. The one exception might be FAP, where we do routinely test children with classic FAP because there are childhood or things that occur that need to be screened for. Okay. Okay, here's a woman with stage 3 ovarian cancer, has typical surgery, gets typical chemotherapy, doing well. Mom had breast cancer, dad had colon cancer, grandma had endometrial cancer. What would you do? Ovarian cancer, automatic. Speak up. Somebody yell it out. Would you do BRCA testing next? All right, was that not one of the automatics? So you do BRCA testing and it's negative. And she has BART as well. We're done? No. No? Lynch syndrome. All right. This is a list of the cancers that make up the bulk of Lynch syndrome. So colorectal dominates, endometrial close behind, ovary, so that crosses both syndromes that we've talked about, stomach, some urothelial cancers, some other abdominal cancers, brain tumors. Now coming into the mix, breast and bladder, some controversy there about what the penetrance is. But anyway, that's the array of Lynch cancer. So if we want to look at this from the Lynch perspective, she had ovarian, father had colon, grandma had endometrial cancers. All right? So mom's breast cancer at older age, a red herring. So in fact, she does get tested for Lynch syndrome, and she carries a mutation in the so-called MSH6 gene. I just want to take a brief side trip here. It's already been alluded to, this next generation sequencing. So in the past, and what happened with this patient, all right, is we did BRCA testing, $4,000. And then I said, well, I'm still suspicious about Lynch syndrome. The Lynch testing, $4,000. A sequential algorithm, that's all we've ever had before. And now what we're going to have is, through this new technology that's called next generation sequencing, the ability to test many genes simultaneously, all right? And this would be a perfect example of, at least in the way that Myriad is doing it, all these different genetic labs are choosing to package and market their things a little differently. When he alluded to the My Risk panel, this is something where we're looking at if you qualify for BRCA or you qualify for Lynch, you get the whole package, 25 genes, for the same $4,000 that you did one or the other. So that's what's coming. So it's more timely, it's more cost-effective, and mostly it's just plain more effective. So again, this would be a place where in ovarian cancer I would find this particularly useful, and we're also going to get all the other ovarian cancer genes as part of that mix. So it leaves us a segue into hereditary colon cancer, which is, I think, again, much more common than many people realize. So we've already talked about the prevalence of BRCA. So what if I ask you this question? If I take all the people in the United States who carry a bad BRCA gene, and I take all the people in the United States who carry a Lynch syndrome, whether they're diagnosed or not, I'm just talking about carriers, and I make a ratio of 1 to the next, what do you think is the closest ratio that's correct? 20, 10, 5, or 1 to 1? Nobody's going to guess.
The way you're asking the question, I would think 1 to 1.
That's a good guess. That's a very good guess. So the answer is 1 to 1. So Lynch syndrome in the population is thought to be pretty darn close to as common as BRCA. Again, we can squabble about what the real numbers might be, but these are somewhere in the ballpark. All right, I've seen estimates where this might even be more common, but you know, I don't want to split hairs. I just want to say that it's in the same range, and yet we do even worse. All right, we're not even up to 2% of all the Lynch patients in the United States having been diagnosed. And then we wonder why the cancers just keep happening. So colon cancer, 150,000 plus or minus every year in the United States. 30% are familial. Within that group, 5% perhaps are hereditary. Maybe it's going to be more with new understanding. And within that, Lynch syndrome is about 3% of all colorectal cancers. Various polyposis syndromes and other things make up the rest. So those are useful numbers to work with, about 8,000 cases a year that theoretically could have been prevented. This is a similar curve to what I showed before for breast and ovarian, Lynch syndrome, colon cancer risk compared to FAP and normal people. So a very significant risk. So here's another woman, 50 years old, 42 at the time of her first screening colonoscopy. She has colon cancer diagnosed. All right, in other words, first time in, bam, there it is. Why was she being screened at 42? Because her father had colon cancer at 52. So I already heard of the arbitrary 10-year rule. All right, that's what was in force, and bam, there it is. Uncle had colon cancer, grandma had uterine cancer, and then got colon cancer. So this is what that family looks like. So I got colon, 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 uterus, and colon. Okay? So these are the questions that were asked at the time that this all happened. By the way, this family was totally missed. Okay? By very good doctors. Very good gastroenterologists, very good surgeons, very good oncologists. Totally missed. How often should she have screening colonoscopy? How about her sister and her brother? How should they be screened? How about her son? 10-year rule again? How about, are you at risk for any other cancers? These were the answers that were given. Oh, you should be scoped every 3 years. Your brother and your sister, they have family history. They should be scoped every 5. Let's use the 10-year rule on your son. See him at 32. She received no other recommendations for cancer screening. Again, painting the whole family with the same brush. So I would submit that there is a better way. We talk about this personalized medicine stuff all the time. Can't we do a better job of matching risk management to actual risk? All right? So, you know, she's got FAMP all over the place in terms of the pattern, her age, multiplicity in the grandmother, and the location of her cancer. And sure enough, she had a mutation in MSH2, was diagnosed with Lynch syndrome. And if you'll notice, again, this was 8 years after her cancer had occurred. So all that stuff I've been talking about has been going on. So now we know she has Lynch syndrome. There's no surprise there. Here's the rest of the family as far as we've taken it. And these are the correct answers to those questions. How often should she be screened now with colonoscopy? Every year in my book. All right. How about her brother and sister? Well, her brother has the bad gene, so he's also going to be annual. Her sister didn't have the bad gene. Average risk. See you when you're 50. All right. How about the son? He was going to do it at 32 with the 10-year rule. He's already 28. He has the bad gene. He should be screened. He's already overdue to start. And what about the risk for other cancers in Lynch syndrome? A few on that list, huh? So these are the ones that actually have effective risk-reducing strategies, all right? Whether they be surveillance or preventive surgery or something. We could argue about how effective it is for stomach cancer, whereas some of these have no effective strategy, like for brain tumors. But this is how I manage these people. Like, we do start them colonoscopies at 25. I go annual at 30 or 35, depending upon what I've seen in the family. I again do screen the uterus and the ovary, even though there's not great data to support that. But as long as those organs are in, past the age of 30, I do something until they can get out. Again, target between 35 and 40. I do use upper endoscopy, typically every 3 years, unless the patient has had gastric cancer in the family, or has had gastric polyps, or is Asian, in which case we screen them more often. Again, we could argue how effective that is, but feel like I've got to do something. Also screen the urine, and there's emerging stuff for endoscopic ultrasound for pancreas screening, but still plenty of controversy there. Just a mention about the phenotype, since you keep mentioning the P part of this. 2/3 of Lynch colon cancers are right-sided. Many of them have histologic clues, such as mucinous or lymphocytic infiltrates, and rapid evolution from polyp to cancer. And I'm going to come back to that in a minute. But these are the red flags, similar to what you saw in breast cancer. We've got some age, we've got some multiplicity, we've got family history, and we've got phenotype stuff, right-sided, those histologic features, etc. Here's some pink flags for you, though. They don't quite make it to the red flag list, but cancer of the ureter and renal pelvis. Boy, you see a lot of those. Yeah, you got a big clinic of those people? No. So for me, you see one of those, my flag goes up. I want to look more closely, all right? Cancer of the small intestine, same deal. Again, colorectal cancer after a clean colonoscopy not very long ago, and we'll come back to that. Sebaceous tumors of the skin, the so-called Muir-Torrey syndrome. Here's something interesting. This is Lynch syndrome plus sebaceous tumors. This is supposed to be pretty rare. I have 6 families with Muir-Torrey syndrome. It's like 13 different patients. And when I tell that to people in genetic world, they go, how in the world do you find so many? Because I started asking dermatologists to be on the lookout for sebaceous tumors. And you'd be surprised how many people turn up that way. So the accelerated cancer formation, you know, the Lynch syndrome with the failure of mismatch repair ultimately leads to something called genomic instability, all right? So if a polyp forms in the colon and it gets that second gene knocked out as a random event, then everything is unstable in there. And while we usually say that to go from a polyp to a cancer is a nice long window, 7-10 years, what we were all taught, in Lynch syndrome, it can be way shorter than that. I have at least half a dozen patients who had a nice stage 2 or stage 3 colon cancer that were less than 2 years out from their clean colonoscopy. All right? Now, what do we as oncologists usually think when we hear that story? They missed it 2 years ago. It's 7 to 10 years. Had to be there. How could they have missed it? Well, in today's world, when you get that scope report back, what does it come with it? Bunch of pictures, and there is the cecum, as pretty and shiny as you could want. There's nothing there. And then 2 years later, the picture is big, ugly cancer. All right? So a take-home message then is, if you ever see that story in one of your patients, think Lynch syndrome before you think the GI doc missed it. All right? So here's another case study. Here's a 39-year-old with endometrial cancer. She has a stage 1A endometrioid cancer. A family history dutifully taken reveals no other GYN malignancies. Father had colon cancer, grandma had pancreas cancer. All right? So when you look at that family tree, I would question who's going to connect those dots. All right? Maybe you would, maybe you wouldn't. All right? So at 45, she has her first screening colonoscopy, has a tubulovillous adenoma in the ascending colon. Why 45? Because her father had colon cancer at 55. So she gets this, she got a TVA. They said, well, we better watch you more closely. You better come back in 3 years. At 48, she comes back. Now she's got adenocarcinoma in the cecum. All right? She undergoes a right hemicolectomy for stage 2 colon cancer. So now she's got 2 cancers. Are you more suspicious now? All right? Now we've got F, all right? We've got A, we've got M, and we got P. Her cancer's in the cecum. Red flags galore. She does have a mutation in the MLH1 gene. Now I will say this, none of that got figured out until 2 years later. All right? This is another one that showed up in the survivor population. But that clue, the multiplicity, but also the clue of her cancer coming out of nowhere. There's the rest of the family. So we have 3 unaffected people that we now know are at high risk and need to be watched more closely. I'm going to breeze through this because I know Dr. Lynch is going to cover some of this, but Lynch syndrome gives us a kind of a different pathway for diagnosing things because we can get some clues from the tumor in addition to doing the germline testing that we do on blood or saliva. There's a stuff called microsatellite instability. Hardly anybody knows what that really is or even what a microsatellite is and why is it unstable. But basically that is an index to the failure of mismatch repair. That tells us that functionally the integrity of the genome is not intact because mismatch repair is not working. This is not a test that's diagnostic of Lynch syndrome, all right? And it's also not specific. 12 to 15% of all colorectal cancer patients have microsatellite instability. I already told you that only 3% have Lynch syndrome. So 1 out of 5 of these people actually has Lynch syndrome. It is about 90% sensitive, however. The flip side of this is immunohistochemistry looking for the mismatch repair proteins. This isn't testing function at all. It's testing, was the protein ever made? Is it expressed in the tumor? Again, it's about 90% sensitive. Again, it's not diagnostic of Lynch syndrome, but it can be useful as a screening test. The only way to actually diagnose it is with germline testing. Sometimes we can narrow it down to 1 gene, but this is what we have to do. There are 5 genes that we can test for. It's the only way to confirm the diagnosis, and it's the only way to get the key that unlocks the puzzle for the rest of the family, all right, to get that mutation. So kind of what's evolving now is, all right, gee, we've left it to the doctors all these years, and they found 2% of the people. Maybe we can do a better job screening people at the pathology level, that is, the actual cancer patients. So there's this trend in a lot of places of doing automatic screening with immunohistochemistry of either all colon cancers and all endometrials or some of them picked by phenotype, but whatever. And if that's abnormal, then it leads to some type of genetic evaluation. These tests are only 90% sensitive though, so even when they're normal, you have to still pay attention to family cancer, and that can still lead you this way. So this is sort of what's evolving, and it's variably in place across the country. But here is one of our cases. We do have this in the hospitals that I work at. Here's a 64-year-old woman with an endometrioid cancer of the uterus. She had a hysterectomy. Colonoscopy had been normal. Grandma had ovarian cancer. That's all we got. But look at that family. There's nobody there. Dad died young. So this is what we call limited family structure, and I do have 2 people. I don't have age. I don't really have a family story. I don't really have anything about phenotype. So who would even think about Lynch syndrome in this patient? Nobody, all right? But there are no red flags. But she had automatic pathology screening with IHC. Her cancer lacked the MSH6 protein. She then underwent MSH6 gene testing. She carried a mutation. So this is a patient that was found only through the universal screening. And that's what the message is there.
Was she skinny?
Was she skinny? No, she wasn't skinny. I don't remember.
I say that as a gynecologist tip is I can look at a patient. She walks in the door skinny and around 60 with endometrial cancer, I think of Lynch. And we found a couple in our practice. No family history, especially with MSH6, you're not going to see that much colon and you'll see more endometrial. So never forget that. If that, we all see that. She doesn't look like your roly-poly endometrial typical patient, that estrogen-driven, think Lynch. And I'll write in my notes, patients that does not have the classic risk factors. And we found a number of them with 0 family history. So I don't necessarily do universal at all. I use less than 60, but I look at the patient and you'll be surprised because the risk factor of obesity is so strong on that common cancer that if they're skinny, that's a red flag in your head.
I do want to make a comment about the flip side of that, though. And this is what I've heard from gynecologists over the years is, yeah, I see some endometrial cancers in their early 40s, but they're always overweight. They're 240 pounds. Therefore, I already have a reason why they have endometrial cancer. I don't need to think about Lynch syndrome. And they don't even look at the family that sits before them that is loaded with other stuff. So, there's it's a double-edged sword there. So, I will go. So how are we doing? I just want to get to our data and then we'll close. All right. So I've already mentioned that our group, we're a large group, 27 oncologists. And historically, we were as bad as anybody could be. In 2004, we tested a total of 28 people across the entire practice. That's 1 per oncologist, except for the superstar who did 2. And we found a giant 6 patients who carried a mutation. These were all slam dunk families, by the way. Our nurse practitioners actually went to a seminar about genetic stuff, this evolving field. And they came back and said, you guys really stink at this. And we said, no, we're on top of this. No, you stink at it. And they did a chart review that they published before they were fired. And they showed just how abysmal we were. I mean, it was embarrassing. So, no, we still love them wherever they are. So in 2005, we did the obvious solution. We hired a genetics counselor, right? Rotate around the practice. And we got improvement, but we didn't fix the real problem, which was doctors had no idea how to identify who was appropriate for testing. So it doesn't matter who's down the hall if you don't know how to identify. So after a year, she's disgruntled, she leaves. We fall back into an intermediate zone of mediocrity in 2006. Again, it's raised as a quality of care issue. We just need to do a better job. Patients were looking to us to do this. There were some liability issues coming because now NCCN and ASCO had guidelines that we weren't paying attention to. So we came up with our own model for how to deliver this care. And the model's not important. What's important is what happens when you start looking, all right? When we developed a program to actually start looking for these people, these are the results that we got the first 4 years in terms of number of people tested, number of people that were found to be carriers. So this has continued to grow, and it wasn't our intent to develop a program per se that other people would refer to, but that's what happened. So this, you guys are the first ones to see this data because I just put it together in the last couple of weeks. At the point where I had done 2,000 genetic consultations myself. I tested approximately 70% of them. 280 patients had an abnormal result. All right, so that's about 20% of the total that were tested. 17% of the total that were tested had a cancer-causing mutation. So 238. 42 people had a genetic variant of uncertain significance. And let me just pause with this genetic variant thing before I go on. Dr. Janicek alluded to it. You know, the great thing about these new panels and these new genes and all this stuff is, you know, we're going to explore more things that we would have done before. But it's also going to be a flashback to 1994, 1995, right? Because the same thing happened when we first had BRCA testing. Genetic variants galore, because there's no database, right? So until a database gets established for all these new genes, when we're talking about frequency and penetrance and management, we're not going to know what to do, all right? But we have to start somewhere, and that's kind of where we are. Of the 238 patients with a mutation, 130 have BRCA genes, 96 are in the colorectal syndromes. So I have diagnosed 68 people with Lynch syndrome, 28 with polyposis syndromes, of which the majority are the so-called attenuated FAP, not the classic FAP, and these are the kind that frequently fly under the radar. So I need a lot of help from my GI brethren in Kansas City to help find these people. This one focuses on the survivor thing. Of the 238, 175 had a personal history of cancer. 115 of those we diagnosed within a year of their cancer diagnosis, all right? Paying attention to the automatics and such like that. But 60 of these people were survivors in our practice, coming in over and over and over again and getting missed over and over again until we put in ways of capturing them. So who do you think is responsible for those people? And if they get another cancer that could have been prevented? You know, whoever the doctors are. Median interval 4.5, mean 5.8. My current winner is 32 years out from their cancer in terms of when we finally figured out what the deal was. So at least my patient, 20 years out, was not the winner on that. So 58 of the 175 were tested because of a single indicator. Remember my list of automatics? Tested based on one of the automatics. So there wasn't that much thinking involved, all right? So I think that's important. So finally, a call to action. I think all types of doctors, whether you're family practice, gynecologist, GI, oncologist, whatever, you all have a role and a responsibility to identify these patients. What if we have a breast cancer patient and we have released them back into the wild? Yeah, they're 7, 8 years out, we've released them back. Now where are they rolling through? Gynecology practices, family practices, you guys have to know and look back at some of these issues. You got to know the automatic indicators. I'd like to make the case to evaluate this soon after a patient's been diagnosed rather than later. Pay attention to the survivors. Periodically update the family history. You have to ask. For patients with colon adenomas, you need to have a feel for how many adenomas they've had, the cumulative number. Is it 3 or is it 26? All right? Don't have to be 26 at one time. And once you have a handle on the BRCA, get busy with Lynch syndrome. All right? This is the, you know, Dr. Janicek talked about the ovaries being the forgotten twins. Well, I would talk about Lynch syndrome being the weak sister to BRCA. It's just as common. The cancer risks are just as high, and yet not enough people are talking about it. So that's why I do like universal testing, a screening of all colorectal endometrial cancers, because I do want to cast that wider net and find more of these people. It's a quality of care issue. These people are right under our noses. We all need to help to prevent their cancers and the cancers for their families. And I will close there. Questions while we're changing of the guard? Or is there supposed to be a break here?
There's a break, but if there's questions, we can do the questions after Dr. Lynch.
I'll do the questions. Any that are burning in your head right now, I'll still have my slides up. Yes, sir?
You mentioned something about sedation.
No, I should clarify that. I was glossing through that. Sebaceous adenomas sebaceous carcinomas. So specifically not sebaceous cysts and not sebaceous hyperplasia.
What about any other skin cancers?
Well, melanoma is part of the BRCA spectrum for BRCA2. Risk is maybe 4 to 7%, somewhere like that. I'm sorry? Basal cell, not thought to be part of either of these syndromes. There are some who believe melanoma might be a small part of Lynch syndrome. I haven't seen anything convincing on that. So, no.
For breast cancer survivors,
Also, that's delayed. She's speaking for Dr.
the
Lynch.
benefit of
After the break.
stratified based on genetic risk versus
I'm not completely sure I understand the question, but are you asking if I've got a breast cancer survivor and she subsequently has an oophorectomy, what's the impact on the survival of for her breast cancer?
Yes.
Well, that will depend on whether her breast cancer was estrogen receptor positive. So everything I'm talking about today has to do with the risk of getting the cancer. Once you get the cancer, its prognosis is pretty much dictated by the phenotype, the biological behavior that you have. What we're doing now is obtaining the genetic signature of that cancer, which is different than what I'm talking about. That's, I think that's what the next seminar is going to be about, what genes got turned on and turned off as this cancer developed, and what clues can we get to its biological behavior, its treatment options, et cetera. So that's all coming. But to answer your question about the impact of oophorectomy, if they were still premenopausal and they were hormone receptor positive, there will be a benefit. I don't know that I can quantify the benefit.
Sometimes it helps us if we're sent a patient who has a variant of unknown clinical significance in their practice, and they're already a breast cancer survivor. And so I've used that as tipping your potential to get to breast cancer as a tipping point to go to surgery even with a variant of unknown significance.
If that's an oophorectomy that you would not have done had there not been a genetic variant, then I think you're on thin ice using that as a justification. I understand your point, and I don't completely disagree. I'm just saying in the traditional view, we would not generally support that. Kind of when you get the genetic variant, I mean, that's the subject for a whole half a day, but for me, interpreting that genetic variant depends on how suspicious was I when I ordered the test in the first place, right? I can give you an example. I had a patient with youngish breast cancer. The family history was florid with every kind of cancer that BRCA2 has to offer. I mean, it was all over the place. And I sat there with that woman and I said, you need testing. I said, and I predict you're going to have a mutation in BRCA2, all right? Just screams BRCA2. And she had BART and the whole thing. She came back with a genetic variant in BRCA2. It's like, and she was the first person ever found with that variant. So there's zero database. And I said, you know what? I think in time this is going to prove to be real. I think we need to manage you as a BRCA2 positive patient, including preventive surgeries and things like that. However, I can't take that variant and take it to her daughter and say, we're going to test you, and if you've got it, then we're going to do stuff with you. All right? You can't extend it beyond that. Conversely, if I got a 42-year-old, and there's zero family history, and there's plenty of women in the family, and I'm only testing her because of one indicator, and she comes back with a genetic variant, I'm managing that patient as a negative until proved otherwise. So I think that's kind of how I look at it.
Geier, I'm a colorectal surgeon here. I'm more medical people, but I'm in practice. We all know that obviously very good but that being said, it's very difficult sometimes in busy practice, not that it's an excuse, but you have to be aware that have you heard of any, or are there any cases of patients from a medical legal perspective being later diagnosed by this maybe another time of suing or canceling earlier. Many doctors.
So I'll give you my answer on this, and then I will yield to Dr. Lynch, who also has the initials JD after his name, in addition to the MD. But for the broad question of liability for failure to diagnose a genetic syndrome, I'm not aware of any cases where you might have picked up this patient with Lynch syndrome or BRCA and you didn't, and a doctor downstream did, all right? I am definitely aware of cases where you didn't pick it up. At the time you were taking care of the patient, you didn't follow guidelines, you didn't pick it up, and that patient gets another cancer that could have been prevented. So the classic case would be the breast cancer patient that you've ignored who then gets ovarian cancer and has a bad outcome. There's definitely liability there. To my knowledge, and again, you might know better than me, I don't believe there's case law because I think all these people, they all get settled out of court. I'm aware of a couple of them that were settled out of court because you don't have a leg to stand on. So what leg would you stand on? The colorectal, whatever your society is named, right, probably has some guidelines about all of this. And if you're paying attention to your own guidelines that were enforced at the time you were seeing the patient, you're probably okay. That's the problem that we saw in the liability issue was that ASCO and NCCN had some pretty clear guidelines, and we were running about 6 years behind in terms of paying attention to them. And I would never say that liability is the reason to do any of this. The reason to do it is it's the right thing to do, but liability is something that we all have in the back of our minds. I don't know, did that answer your question?
Amazing to me that with all these guidelines in today's day and age, how many are even the obvious ones every day? Well,
I think we are getting better in BRCA. I think we're pretty slow to get better in Lynch. And I think part of it is in breast cancer, you know, we no longer do the, oh, you got biopsied on Tuesday and you're having your mastectomy or lumpectomy on Friday. All right, we don't do that anymore. There's a whole bunch of steps in between. In colon cancer, you get your colonoscopy diagnosis on Tuesday, and you may very well have your hemicolectomy on Friday, right? And if you're doing that because you were obstructed or bleeding, then you have to. But if you don't, and I didn't present a case here today, but I have some GI doctors and surgeons now who are going, wait a minute, this is not urgent, all right? We can get your surgery done in 3 weeks just as well as we can this week. Let's do this other, particularly if it's a female and who has her uterus and ovaries. So, any other questions before I can turn it over? I know we're all running behind, so. All right, thank you.